seems to me that there is, let's say, at least for people who fasted or intend to fast, there is a kind of peak in the GCC countries, and there is a kind of gradient in let's say, in both sides. So we can, I saw, and this is maybe an external point of view, that maybe Egypt, there is a kind of gradient, Egypt and the Maghreb countries, but also in the other side. And we saw Pakistan. And when we go to the north, it's similar, like Turkey and UK, it's similar a little bit to the Maghreb countries. This is my, but this could be maybe also good questions for discussion. So over to you, Professor Bolton.
Well, thank you very much for an excellent session. All very clear, the talk summarizing the problem. I would encourage any of our delegates to submit questions through the Q&A box. We don't seem to have any questions. So perhaps I could start with a general question. And looking at the prevalence of complications across the region, there seems to be a huge difference. For example, Mohammed Hassanein showed less than 20%, I think, in Egypt and Egypt and Turkey was 45%. Enas, whereas Mohammed was showing less than 20% in Saudi and UAE. I just wonder if you think it's something to do with measurement, or is there a true difference in double the rates in Turkey and Egypt versus the Middle East?
If I can volunteer an answer, Andrew, I think this is probably investigators' bias, because this is not a fully comprehensive survey from across the country. In some countries, it was very comprehensive. Credit to my colleague in Saudi Arabia, Reem Al-Amoudi. She organized a huge number of investigators from Saudi, so the data was from all over the country. However, in some other places, it's mostly secondary care, perhaps versus primary care. And hence, we need to not really compare between one country and another and look to the overall rates of complications and problems related to Ramadan.
Another observation that I've made is that the large variation, as the last speaker was saying, from Saudi, the people not responding to hypoglycemia when fasting, which is clearly, as each of you has emphasized, a serious problem. I just wonder, education alone may not be sufficient. How can we address this to stop potential fatalities?
I think it should be part of the education which is granted. And because hypoglycemia, even doctors put a lot of emphasis when they are educating, and especially for type 1, when the family is concerned as well, they push a lot. Hypoglycemia, unless it gives significant symptoms, polyuria, thirst, hypotension, they keep going on. They will say, I will lie down, I won't want. So I think it's incumbent that the education puts the emphasis in a way. But as we see in our type 1 or type 2 patients, they are always finding reasons and are reluctant not to break the fast. So I think it has to come both from the educational physician as well as from our religious scholars as well, that when there is a situation when your health is at risk, you have to take the precedence and you can compensate later if needed, which is again not needed. And I think this part is important to be educated, because if you're breaking your fast for some medical reasons, for saving your lives or health, etc., it doesn't need to be compensated in the religious way.
And I was really referring to hypoglycemia, but we do have a question in the box now, and I'll give this to perhaps the last three speakers. What's the rate of more hypoglycemia or hyperglycemia noted in patients predominantly with complications? In other words, patients at high risk who might be discouraged from fasting? That's a question.
Thank you very much, Dr. Dalal from Bahrain. Please stay with us for my presentation on diabetes duration and age. And the answer for this will be it's my full presentation related to that point. Yes. So in half an hour or 20 minutes, you will get
the answer. There you go. Okay, we have 2 minutes left until the official end of this symposium. I just wondered if any of the other speakers or my co-chair would like to ask a question. Hisham, perhaps?
Well, thank you very much. Yeah, I think this is a great discussion, and even from WHO perspective, I was wondering how maybe we can think about it. And I think as Professor Hassanin said, I think there are a lot of answers to even my questions when I look to the agenda. I think there are a lot of questions, but I think it will be during this I think the other also the next presentations. Well, I think we are
one more, Ines. Brief now. We're
I just want to stress the role of imam, of the religious authority. We have maybe to speak to the religious authority to be helpful in allowing patients to break the fast if they have any complication, because the patient sometimes become afraid of any sensation of guilt or something if he breaks the fast. So we may stress on the religious authorities to speak the same statement like DAR and IDF recommendations.
Thank you very much. That's really an excellent point to finish with. That's the importance of the religious authorities to reassure people that if something is life-threatening, they have to break the fast, such as severe hypoglycemia. If I'm correct as a non-Muslim, but I think that's what I was hearing. So I'd like to thank all the speakers. We've had an excellent session, very clear, concise talks with succinct messages, and that's what I would expect with a panel of speakers like this. So I'm very satisfied, and I'm sure my friend and co-chair Hisham Al-Berry from Cairo is too. So I think I will now hand back to your overall chair, Mohammed Hassanan, who will probably introduce the details of the next session.